as a bariatric surgeon, and I hope by the end of my presentation, all of you will agree that we have to accept that, yes, we have a future here, but we shouldn't be worried that we will be losing our job as in bariatric surgeons. So this is my disclosure. I've been doing 2 studies for Novo Nordisk. One is Redefine and one is Reimagine 4. And 90% of my surgical work is either lap or robotic bariatric surgery. Training from India, AIG Hospital. So we know that everything comes at a cost. That's what Serena Williams said. And it is just what you are willing to pay for it. So the question is, do we really need drugs for obesity? We know that bariatric surgery is a gold standard accepted method for weight loss and comorbidity resolution, but there is a bigger problem. Now let's look into the data. Now this is the data of ASMBS. Look at the number of sleeve which has gone up from 28,000 to more than 1,52,000. Look at the number of RYGB which is going down and down. Look at the revision surgeries which is increasing enormously. And obviously the new procedures which are coming up. So what do we learn from this data? The sleeve are increasing, RYGB are decreasing, and there are a lot of new procedures as well as a lot of revision surgeries. So sleeve has overtaken RYGB over years, we know, because there are a lot of complications or long-term problems with RYGB. So does the revision surgeries, because we are doing more sleeves, so more weight regain. So what is the elephant in the room? The biggest elephant as in bariatric surgery, what I see is insufficient weight loss and weight regain, which happens after bariatric surgery. So it could be, person loses weight and then regains, some of them don't lose weight as expected. And it can be really bothering for them because they spend a lot of money. They took such a great risk to undergo knife. And then if you're not doing good, it makes them worry. So the data says that 1/3 of population who undergo bariatric surgery, they regain their weight eventually sometime in their life. We know that I've specifically written these things in a very small letters because none of them work actually. When you talk about weight regain, we have already tried nutritional, behavior therapy, and psychological lifestyle intervention, but unfortunately, when everything fails, you have to rely on something which is pharmacotherapy. Now let me take back you to the history. When the first laparoscopy and when the laparoscopy was invented, this guy was criticized like hell because everybody was doing open surgery. But the time proved that this is the future. The same stands true for the newer medications which have come up. So I shall not be talking about the lot of medication which are already being used, but my target would be the GLP-1 analogs which have gained a lot of popularity, and my presentation will be specifically related to weight regain, not just per se treating obesity. So there is one publication which was very recent, and it says that in 50 patients who had regained weight and they started on GLP-1, so the total body weight was around 8.8%, and 75% of patients lost their weight and about approximately 5% of them maintained it. The adverse events were very minimal, as quoted, like gastrointestinal, like nausea and vomiting. And these studies are all consistent with the previous trial, which were related to using anti-obesity medication without any bariatric surgery. But the interesting thing here is semaglutide proved to be better compared to liraglutide in weight loss in post-bariatric patients. Now there is another study which was published in 2022. They had 422 patients with weight regain or insufficient weight loss after bariatric surgery, and out of that 150 patients were placed on pharmacotherapy and 27 underwent revision surgery. And the mean age was 41 years and the BMI was 42. The most common conversion surgery was LSG to RYGB, and the total weight loss was higher in insignificant weight loss group compared to weight regain group, in revision surgery, which means that people who have not lost weight or have insignificant weight loss after primary surgery, they had better results with revision surgery compared to people who had been put on pharmacotherapy for weight regain. They performed better. So patients with insignificant weight loss or weight regain had, obviously in both the cases, revision surgery worked well, but for weight regain, pharmacotherapy was better. Now this is another paper published by Rubino. They had 36 non-diabetic patients with obesity who had bariatric surgery and regained weight. They started on daily liraglutide of 3 milligram during the first week, and 13 patients were excluded, obviously because of different reasons. The 23 patients who completed the 6 months and 11 were switched on to liraglutide alternate day, and 12 continued with the liraglutide 3 milligram daily. Now the interesting thing is the average weight loss of 17.9% with daily liraglutide 3 milligram was unusually large, which means that patients who were in the previous studies, the patients who were put on liraglutide in the RCTs who never had surgery, so these patients had better results. So to end my slide, I want to say all of science is nothing more than the refinement of everyday thinking. So we should be welcoming anti-obesity medication, because if we don't accept, the endocrinologist are going to take over it, and then it will be a problem. So I want all of you to be part of the trials related to anti-obesity medications. I want you to welcome them with an open mind and read more about how these drugs work, because in the future we want to be obesity surgeon and physician and not just the bariatric surgeons. Thank you so much. Yep.
Not mistaken, I think you showed the difference between the response of patients who have inadequate weight loss compared to weight regain. Do you have a reason for that?
So in one of these studies, that's what they found, that if a patient has insignificant or inadequate weight loss, revision surgeries are better compared to these drugs. Probably because there might be multiple reasons. It could be patient-related reasons. It could be related to the type of surgery, the surgeons, how sleeve was performed. There could be many reasons. But they said that if a patient has inadequate weight loss, revision surgeries prove to be better compared to drugs. I don't know in depth what could be the reason. They haven't mentioned that.
Have you, Abhishek, had a chance to read Alex Miraz's paper on use of drugs for recurrence of weight gain?
Yeah, I've gone through. Yeah.
That does show that there could be a pretty decent number of people who might at least lose. Even endoscopy today is being used for recurrence of weight gain for a lot of the patients, either pouch reduction or stoma size narrowing with or without the endoscopic mucosal resection. So do you believe that you should jump straight to surgery and not give endoscopy or some of the AOMs a chance?
See, if I was in the place of a patient, I would definitely go for something which is less invasive first. So I'm not against it. I'm just saying what paper said. Definitely, if somebody has an inadequate weight loss or has weight regain, we have to look into a lot of parameters. We shouldn't be jumping on revision surgery, because that's why initially when we had patient with weight regain, a lot of patients jumped directly onto the revision surgeries, and they burned their hand. So we shouldn't be jumping on the revision surgery as a first parameter for weight regain or inadequate weight loss. There has to be a complete evaluation, and once we are sure that okay, there's nothing left, nothing is working on that particular individual, then we can opt for revision surgery, just in case of weight regain.
Was an interesting paper this morning, I'm not sure if you heard it, about phenotyping patients, whether they're brain hungry or
Yeah.
gut hungry.
Yeah.
Maybe that will be the answer
Yeah.
in the future of how we manage our patients.
So I didn't mention it. This is called hedonic kind of obesity, wherein it's not that person wants to It's not hungry actually, it's a brain which wants you to eat more and more. That's what this concept of phenotype or genotype is coming up. And that's why we have seen even patients who are put on anti-obesity medication without bariatric surgery, not all of them respond the same way. So probably something to do with genes.
No further talks. Thank you so much to you all for being here. Thank you.
Thank you.